Our next speaker is Leonard Schaeffer. So if we think about big data, let's also think about some of the big things that have happened in the last several years. And certainly the Affordable Care Act is one of those things. Our next presenter, Leonard Schaeffer, will focus on some of the critical elements of this watershed legislation. Leonard is a professor at the University of Southern California, where he holds the Judge Robert Maclay Widney Chair. He is a graduate of Princeton University and was the founding chairman and CEO of health benefits company WellPoint until he retired in 2005 to focus on developing sustainable public policy solutions for our nation's most pressing healthcare issues. Leonard's topic is ripped from today's headlines. Let's listen to him as he presents the Affordable Care Act. Change is the only constant. Thank you.
Okay, well, good morning, and I was going to begin by complimenting Harvard Medical School on having not one but two Californians on your program and putting them on first. And then I got bumped. My only comment is that I've been thrown out of better places than this. We have been, all of the speakers have been under relentless pressure from the staff to make sure that our presentations could be completed on a timely basis. And I have my presentation down to 8 slides. However, the pressure was still mounting, and I've now got it down to 5 dot points, which I think is a testament to my editing ability. My computer ability, however, is so poor I could not generate a slide. So I'm going to read the 5 things, and you will have it all at once. The first point I want to make is that healthcare spending drives future federal deficits. Second, deficits add to the accumulated national debt. Third, the accumulated debt is a major economic and national security problem. I want to go through both of those things carefully. Fourth, therefore, if healthcare stakeholders don't cut costs and improve quality, a combination of deficit hawks and national security people are going to force changes well beyond anything in the ACA, which parenthetically isn't going to be implemented as written in any case. So there are going to be significant predictable and unpredictable changes in healthcare over the next decade, coupled with unrelenting demand to reduce costs. That completes my presentation. Nice to see you all. However, I have 6 more slides, so what the hell, okay? What's the problem? This is the problem. This is a CBO slide, and what it shows is that our accumulated debt, I'm not arguing against deficits, but our accumulated debt at the end of this year will be 73% of the gross domestic product. Now, that is not an all-time high, but it is the high since 1950. And the question is, what's going to happen next? If current law plays out and we do go off the cliff, okay, and this is what the law says and what the president just recently said is off the table, it will drop to about 58% of GDP, which would be the highest amount since 1953. If we go with our historic trend, that is to say we don't do all the things, we don't do the sequestration, we don't do some of the other things that are over the fiscal cliff, it'll grow to 90% of GDP, which would be the highest since 1947. Now, what's important to understand, and I'll come back to this in a minute, is that U.S. debt holders today, 53% of U.S. debt holders today are non-U.S. entities. China is the largest, Japan is the second largest, and the UK is the third. If you talk to bankers in the UK, they will tell you that that debt is being bought in the UK by the Chinese. We'll come back to that in just a minute. So we are in major difficulty with our debt, and it will have a big impact on our economy if we don't do something about it. What's driving the debt? This is a GAO chart, and I know it's very complicated for an academic audience like this, but if you look at the colors, what you'll see is, according to the GAO, yellow is all other spending, and basically it remains pretty flat. Social Security, which is allegedly the big bugaboo, grows a little bit, but not much. What is driving the deficit is healthcare spending, Medicare and Medicaid, and interest on the debt. And if interest rates goes up, this is an underestimate of the deficit we're gonna see. The straight line and the dots are the historic averages for revenue. And historically, revenues in the United States have run about 18 to 20% of GDP. And what you see is a dramatic growth in our deficit, and it is literally unsustainable. So what's going to happen? Now, current law, that is to say the ACA, says we're going to do the following things to implement that piece of legislation. First, federal and state regulators are going to successfully implement health exchanges in every state and increase Medicare increase Medicare in each state based on what that state decides to do. Courtesy of the Supreme Court, some states can opt out. So we don't know exactly how many people are going to be eligible for Medicaid, but it's going to be a lot of folks. Just doing that strains the ability of regulators and elected officials across the United States. On top of that, we're going to establish something called the IPAB, which is going to constrain healthcare cost growth to the rate of growth of GDP plus 1%. Never been done, okay? And courtesy of the Congress, all of the logical levers you would use to do it are not on the table. So these guys have to use basically moral suasion, and what they come up with can be overturned either by the Congress or by the president. There are a bunch of other things in the bill that are supposed to happen. The out-of-pocket premium payment for people who have insurance is supposed to go up in order to slow the cost of the federal government. The excise tax on Cadillac plans is supposed to be indexed to the CPI. A whole bunch of Medicare demonstrations are supposed to be successful and then successfully implemented across the country, and individuals and small businesses are going to get affordable health insurance. This is a very complex, a very ambitious bill, but a very complex piece of implementation, and everything's got to go right to achieve the goals of the legislation. Let's take a closer look at this. And I'm not going to take you through all the details, but I will explain the Christmas colors. The green has to do with expansions in coverage. The red are things that are going to control cost or are game changers, are going to make life much different. The important thing to understand is this bill feathers in over time. Now, to go back to my earlier comment about implementation, this is good for implementation because you can plan and hopefully get it done. Okay? This is very bad politics. What this does is create time-specific targets for people who don't like the specific changes, and they are organizing now to make sure that those changes don't occur. The history of healthcare legislation is the debate is never about healthcare. It's about something else. It's about the role of government, it's about tax policy, it's about religious principles, it's about social values, it's about my little industry and how this is bad for small business or large business or international affairs or whatever the hell. And when you break these things down to small pieces, they sound logical, and the Congress and state legislatures take action. It's pretty graphic when you look at how the bill is financed. There are 14 different tax increases, and I'm including penalties as tax increases in the bill. Very good ideas by the most part, but the point of the story is there are 14 groups organizing today to amend those either out of existence or to change them in some way, and some of those are going to happen. There are $716 billion in cuts, primarily Medicare. The second rule of politics is old people vote, poor people don't. Okay? This is not going to happen, in my opinion. Okay? And we'll get back to that in just a minute. Why should we be skeptical about this being implemented? Well, one is the implementation difficulties, but the real issue is that there is no constituency in this country for reducing healthcare costs. Every cost is somebody's income and somebody's treatment. Providers, and I have great respect for healthcare providers, basically believe that they are doing the right thing for their patients, and if we're going to reform healthcare, the first thing is to give me more resources. Okay? If that isn't going to happen, there's a chance that somebody else might get more resources, and that means I might get less, so my second choice is no change. And the history of healthcare reform not happening has been a function of that argument. So most providers want more, not less, or they don't want any changes. Consumers want everything. patients, and they want them now. There is a thing called demand pull, and patients are very demanding of the healthcare system. So they're not really in favor of controlling costs. Employers want costs to go down, but fundamentally, employers want happy employees who do the work of the employer, and they do not want to be up front trying to control costs. Policymakers, which is a nice word for politicians, basically want no controversy. Remember the second rule of politics: old people vote, poor people don't. Parenthetically, the first rule of politics is I must get reelected. So the second rule becomes very important. Policymakers also view healthcare differently than anybody in this room. One of the reasons that hospitals are so powerful in politics has nothing to do with healthcare. Hospitals typically are the largest employer in their geographic area. Okay? It's about jobs and it's about local pride. Okay? And elected officials don't vote against jobs and don't vote against local pride. The bigger issue, if you're an economist, is that healthcare entities tend to optimize at the local level and sub-optimize the system as a whole. So what we have is a leaderless healthcare system with no one responsible for the entire system, and since no one benefits if the system improves, what they really care about is their piece of the pie. So what will happen? Well, we have a 10-year rollout in this bill of time-specific targets for change. And as I mentioned earlier, people are organizing as we sit here to get changes that make sense to them for their own reasons. And there are a whole bunch of changes that have already occurred, both from the regulatory side and legislation has been passed. Sophisticated stakeholders will build support for their particular self-interested change, and it won't come across as changing healthcare. It'll come across as something that's important to small business or something that's critical for international trade. There'll be lots of new bills and I think waivers at both the federal and the state level that will result in piecemeal replacement of provisions. Now this becomes very important because this is an extremely complicated piece of legislation affecting an extremely complicated part of our economy. So you get unintended consequences, and we cannot predict what those changes, what this change over here will do to the system as a whole. You're also going to see, I think, tremendous variation among states. Some states are already close to making this thing work. Some states haven't started, and some states are depending on the federal government to set up their health exchanges. One of the big things that happened fairly recently was in the bill there's a requirement for what are called essential health benefits, which sounds logical. There ought to be some benefits that are essential, but nobody's actually been able to figure out what they are. They were supposed to be put into the health insurance policies that are sold in these health exchanges. The authority to determine what is an essential health benefit has been delegated to the states. So there are going to be 50 different versions of that across the country, just as an example. Okay? And we'll see, I think, some interesting outcomes and probably a lot of lawsuits. So the unintended consequences from narrowly focused changes will interact with the rest of the ACA and the reality of how the healthcare marketplace works, and we will see some unexpected outcomes. So the point of my presentation is I think we will see 10 years of operational and legislative uncertainty and truly unpredictable change. So the question is, are you ready? You got to look at four different things. First, in the ACA, there is a list of things that are supposed to happen. And as I say, implementation is a challenge, but if you're in the healthcare world, you ought to be able to take a look at that and see where you want to be. The problem is that people are going to be advocating for changes. I don't think anybody needs to repeal the Obamacare. I don't think that's going to happen, but I do think the number of changes to it will fundamentally change its character over time. And those changes, as I said, will come from narrow advocates, and they will pass through Congress and through the state legislatures. And they're unpredictable, both in terms of what the changes are and what their third and fourth level consequences are. I wouldn't underestimate this issue of the national debt. I'm going to take a minute to talk about this. David Walker tells a story about Eisenhower and the Suez Canal. This may sound far afield from healthcare, but it's instructive. So the French and the English in the 50s decide that they want to take over the Suez Canal so we can get more oil coming to the West. And apparently they asked the United States if we would join in, and Eisenhower said no. So they did it anyhow and didn't tell Eisenhower. And one day he wakes up and there are British and French troops in the Suez taking it over. And apparently he gets a little pissed off, and he calls the Secretary of State, who according to David Walker, calls the Prime Minister of Britain and says, "Hi, understand you guys have invaded the Suez Canal. I got one question. Who buys your debt?" Okay, well, you do is the answer. Well, we used to. You guys either get out of the Suez Canal or we're not buying another pound of your debt. If you recall, they left. Okay? The issue is what happens if the Chinese decide they want to do the same thing to us, or more probably, what happens if we get between a Chinese and a Japanese fight, okay, which is happening right now in terms of those little islands in Japan. Okay? There are lots of reasons why stopping the debt doesn't make economic sense, or stopping the purchase of American debt doesn't make economic sense, but there are lots of reasons why countries go to war. There are lots of issues around what people think is important at a specific point in time, and this is a major national security issue. I mean, major. And the national security guys don't mess around. So if the people in the healthcare system can't change our system to make it lower cost and higher quality, or at least bend the curve in terms of increase in costs, there will be an unholy alliance of deficit hawks and national security guys, and they will cut. And they will cut mercilessly because it's about our nation's security. So the healthcare end of it will be collateral damage, but we will have to deal with it. That completes the paid political announcement. Thank you very much.
Sure.
Well, you used words like uncertainty, and you didn't quite say that you weren't optimistic, but I'm interested. Are you optimistic that we're going to be able to make some of the changes that?
No, I'm extremely pessimistic in the short term because of the second law of politics. Old people do vote, and elected officials are going to be very reluctant to make significant changes. I think there is change afoot in the healthcare community, and I think over time we can become more efficient. But it will take time, and we will have, I believe, some very rude shocks, along the way. But Harvard could help a lot if we could train physicians to focus on how care is delivered and at what cost, as well as the quality of that care.
Are there any things that are not in the ACA that you think are important changes that could actually bend the Medicare cost curve?
Well, the Leonard Schaeffer view of the universe says that we have to change what we pay for and how we pay for it. And we can talk about that in terms of bundled payments and capitation and paying for outcomes as opposed to paying for process. I also think we want to move prevention out of doctors and hospitals and into schools, teachers, and parents, and do it at the very front end. And then finally, I think we have to deal with end-of-life care, and as I think a previous speaker mentioned, put patients in charge or give patients the authority to make decisions about interventions as they approach end of life. Those are all difficult issues, and that's why I am fairly pessimistic. The worst possible case is what we have in sequestration. What that bill does, and it's a political issue that you ought to be very conscious of. If we go through sequestration, it's a 2% across-the-board cut in Medicare. Now, the second law of politics says old people vote. You can't possibly get away with that. Well, you can when you label it, we're not reducing your benefits. What we're doing is cutting payments to providers. If you can do 2% in year one, you can do 5% in year two and 5% in year three. That's terrible because it doesn't change the way the system works. it doesn't improve quality, and it doesn't really reduce costs because nothing personal. Providers will just increase the number of units in order to hit their target. So that's what I would do. It ain't going to happen.
Let's okay, let's talk about the states for a second. They really have a lot of power in this. What do you think are going to be some of the key outcomes at the state level, and what do you predict of that? And then what would be your wish list for the states?
Well, I think there's really good news and bad news. The good news is by having states do this as opposed to all come from the federal government, we're going to have lots of interesting experiments. There will be creativity. There will be new models. I think that's all positive. The downside is, you know, it'll work or work well in one state. Query, will that work someplace else? Query, will you be able to export the successful models from one state to another state? So it's, you know, plan very carefully to live in the state that does it right, and not to be in the one that screws it up.
But you wouldn't want to make any votes on what that state would be, would
you? Not me. I will say, though, that I have a house in California and one in Massachusetts. So.
All right, so you're covered. You're covered either way. Yeah, clap for that one. So thank you so much.
Okay.
Let's keep watching it.
All right, my pleasure.
Thank you.